edit it anyway.
Yeah.
All right, my friend, Dr. Joe Abbott, clinical biomechanist. Let me do that again. Hello, Joe Abbott. I can't even start this.
Take two.
Take two. Good morning, Dr. Joe Abbott,
Good morning,
clinical
Diane.
biomechanist and researcher. I'd like to ask you some questions if
Cool.
I can. Let's start by answering probably a big question. Can you tell me how your experience with ISM, the integrated systems model, had changed, or if it did change, the direction of your PhD studies?
Yeah, that's a really loaded question, because before I came across the integrated systems model, I'd spent quite a bit of time with Professor Andre Vleeming, and I met him and did some courses with him, and then had a dinner date with him to have a conversation about failed load transfer within the pelvis in the sacroiliac joint, and his work on form and force closure. I've always had an interest in lower back pain because I've been a chronic back pain sufferer. So I was interested in continuing the conversation with him, but looking at it a little bit differently to how he was doing it. And during a conversation with him, he said that I really needed to meet you to look at the system that you use and see what I thought about it. So I think it was within a year, I then was allowed to attend the women's health course. And it was then that I kind of started to get some more ideas about how clinicians were applying form, force closure, failed load transfer, looking at the control of the pelvis in quiet standing to load transfer. So then it was a matter of trying to tune in more specifically to what was happening, which is why I then signed up to do the integrated systems model at Akasha.
Because Can I interrupt for 1 second?
Yeah.
So was there a difference in the sense of what Andre thought was happening mobility or control wise in the pelvis versus what you experienced? I thought. Were we on the same page or different?
You were both on different pages. Andre and the teams that Andre's worked with were saying, the movement at the sacroiliac joint was so minimal that it's null and void. We don't need to consider it. Yet when I attended the women's health course, and obviously I've worked with other clinicians in my timeline, and I've had clinicians work on my body, I know that they're looking at something around my pelvic area, like one-legged standing test. So I knew I just needed to understand why there was a different conversation between somebody as pioneering as Andre to how clinicians were utilizing and what they felt in their hands, what they believed they felt in their hands. So then when I decided to take the integrated systems model at Akasha, the whole premise of why I was there, and this, was to try and falsify what you guys believed you had in the hands, because Andre had all of these mechanical and these high level research studies that had demonstrated that the movement's insignificant. So why is there this huge population of manual therapists that are still using those tests? So I was really there to falsify you, to falsify clinicians, really, because as far as Andre was concerned, the models he used and all those wonderful studies he'd done, that was not true, what you guys were saying.
So to clarify, what we were saying is that we could feel the SI joint move.
Yeah.
From Andre's work, we had believed that when you transfer load, it shouldn't move.
Right.
And we were picking up people or patients for whom the SI joint was moving when it shouldn't. And all of this was detected through our hands.
Yeah.
And we were being challenged that the movement was too small. What you're feeling is just skin movement.
Yeah.
It was written off as you can't possibly feel it for two reasons. Number one, the movement's too small.
Yeah.
And number two, you guys are not reliable with what you do with your hands. And
Yeah,
stuff
but I
like,
think the other thing of interest really was Andre had beautifully described, and his team, obviously he had a team of researchers with him, but he had described what should happen, but he had also described what shouldn't happen. And that's what I found really interesting, because when you're working with clinicians who are looking at that as part of the picture of, you know, of somebody, the reason why somebody's attended an appointment, they were finding more of the what shouldn't be happening. And I found, I thought that was of interest. I didn't know whether it is a clinician's bias that, oh, Andre's written about it, this person has pain, this is poor control, this is a non-optimal pattern, so we'll go with it. And obviously Barbara Hungerford had also looked at those patternings in the one leg standing and weight transfer. So nothing really for my PhD, which was about lower back pain in the general population and not a sporting population, I had no clear answer to where I needed to go. I had the researchers saying one thing, but the people I needed to do my research with were the clinicians. But then the clinicians were seeing and feeling the complete opposite to what was being written in the evidence-based research. So it was a massive stumbling block, a massive, massive problem to trying to do the research on back pain when people that are doing the testing and the assessments are not finding what the researchers were finding. And then when I got to the point where I was like, okay, I'm just going to use lots of clinicians in my research to assess somebody, to enable me to understand what's happening in this person's body. I then looked at the evidence on clinicians using their hands as a measurement instrument in clinical practice and research, and the biggest problem arrived, which was you're unreliable. Anyone using their hands, well, no, let me get that right. Now I've done 8 years of research on this. Practitioners of manual therapists, when they use their hands, they're unreliable, but not surgeons, not phlebotomists, not nurses, not critical care nurses and people that work in ITU. They were allowed to use their hands and they're
no,
reliable.
but they weren't tested.
No, they're not tested.
Yes.
They're not, but they're okay. We don't have to test them.
Yes, but you have to test practitioners
We
of
have to
manual therapy. We're the only group that have been
Only group.
scrutinized.
Only group. If you look
But
at
that's okay. Put us under a microscope.
Yeah.
I still believe
Yeah.
that we can be reliable, and I still think it's the methodology of the research trials.
But the frustration is when you're doing a systematic review on inter and intra-tester reliability studies, the researchers who are doing the research on that are using their hands to then inform either the intervention or the inclusion criteria. So it's okay for a researcher to use their hands to pull in a population to be part of a study, and even if that's 3D motion capture or 3D mocap, we have to mark osteological landmarks and put markers on them. It's okay for us to do that.
Yeah.
And we, as biomechanists, we barely touch human bodies compared to clinicians. And we're going to say that the hands are unreliable, but it's okay for us to use it to then inform a gold standard research project. No, something was not right. There were so many obstacles to trying to complete this PhD, which is why it took as long as it did, because there was no agreement. There was no agreement between what it was more about bias of population than it was, i.e. bias about putting you guys under the microscope. We didn't put biomechanists under, we don't put researchers under to test their hands, we don't do surgeons, we don't test surgeons. And yeah, it just became a very dirty subject to try to find any clarity in.
Well, those studies have had a huge impact on our profession, on my profession of physiotherapy, because manual therapy schools are closing, young therapists are not learning how to develop their hands in a way that is needed to be reliable and accurate. And the whole direction of physiotherapy is changing based on those same studies
Yep.
that in your PhD you have determined or discovered that the methodology of the research in itself has failed to inform practice. So our profession is totally going in a direction based on bad research or flawed research.
Flawed research,
Flawed
yeah.
research.
When I did
What's flawed about it?
Okay, so when I did the systematic review of inter-tester, intra-tester reliability studies, it's, I think what we've got to understand is, what are we trying to say the hands are during a manual assessment? Well, we're saying they're the measurement instrument of choice.
Right.
If I want to take your temperature, I use a thermometer. Now, if I'm using a thermometer as a measurement instrument, there are two criteria it has to meet. And number one is it has to be valid. And number two, it has to be reliable. If you have validity, you have and you have reliability, you now have a measurement instrument that should perform and give you accurate measures. So I would never use a thermometer to measure distance, because that's not a valid and reliable measurement instrument. So I think when it comes to looking at all the studies that have informed practice, that have influenced the world of populations when it comes to clinicians, manual therapists that are now coming away from using their hands, is based on flawed evidence.
Why?
Because we should never be looking at reliability unless we've done validity. If I say these hands are going to measure where your pelvis is in space, and if you have failed load transfer in the sacroiliac joint, I'm saying that my hands are a measurement instrument. So before...
That can feel the in suboptimal movement happening.
Yeah, can feel anything.
Okay.
It can feel picking up a pen to writing my name on a piece of paper. If I'm saying that is the measurement instrument of choice, I have to create validity for this to be used as a measurement instrument before I test reliability. However, for 70 years, all we've ever done on this is reliability. We should never be doing reliability on the hands until we got validity. So every single piece of evidence that has ever been written testing the hands as a measurement instrument has only looked at reliability. That is flawed evidence as far as I'm concerned, because we have to have validity. Once we have validity, we can then test reliability. So all the evidence that's informing a manual therapist to come away from using their hands is flawed. And whether my research is published or not is irrelevant. It's completely irrelevant, because if you look at how do we make any measurement instrument gold standard, we do validity. And it's not out there. So even before my research is published, it's flawed, categorically flawed, because nobody's done it. Nobody's looked at validity. My research has looked at validity, and that's what will be coming out soon.
So in part 2 of this, or the next part, we're going to talk about what is validity and how do you determine whether the hand is a measurement instrument and has validity. So stay tuned. Long enough.
Good?
Yeah.